So it's a pleasure to be here, and thank you for reminding me of my mother's time in biomedical engineering and clinical informatics. When I was going through her material of an age when our parents have passed away recently, I found all kinds of slides and diagrams from the 70s, letters to the dean of the medical school at UCLA suggesting that something just changed, I'll ignore it, that they might want to consider starting to have some conversations between the medical school and computer science around the role of data and data processing in medicine. And the dean wrote back about commenting that he wasn't sure it was all that relevant and necessary of a discussion at the time. Anyway, some wonderful things back then, and the discussions haven't changed that much. I've only really come to look at things around health in the last decade, and I wandered there through the technology. When I was here, and in the decade plus afterwards, it was the time of internet protocol development, and my native tongue, if you will, and still my creed is open modular architecture, and all that can and very much has brought to the world. And I did some work in distributed sensing, and around a decade ago, smartphones started emerging, and I became very interested, as a lot of people here did even before then, on the role of PDAs and mobile phones and such as bringing us data about people. And if you have data around people, then one of the most interesting things there is, in fact, about people and their health. So wonderful and difficult acts to follow. I just wanted to follow up, in particular in the context that we just heard, and talk about the components of people's health that are determined not so much by things like genomics and their likelihood to respond to one drug or another, all of which are tremendously important and influential priors, if you will. But then there's the other component of what determines in what health state people come in, to what extent they adhere to their therapeutic recommendations. And there's an opportunity with all that mobile, not only in the hands of the doctors, not only in the hands of the caregivers and family members looking at the state of patients, but also, of course, the reason that's all happening is because the phones and the mobile data are with almost everybody almost all the time. And there's a tremendous opportunity to use the keystroke analytics from individuals as consumers and patients, as well as doctors. And that two-part benefit of this is it's capturing our interactions and what can that tell us about ourselves, and it's also our primary interface to the world, and therefore a source of influence and both incenting and incentivizing. So in this context, this sort of small data perspective, it's the same data. It's just a different slice at the problem. So typically when we talk about big data, when you have the opportunity to get to the data around the last 10,000 patients with this particular condition who were similar, you can go and look at what was most effective. Tremendously important. And when you do that, you look at lots of sources of data. But as a hospital system, as a clinical system, you're looking at clinical records. You're not also looking at what those people purchased on Amazon, or who they friended on Facebook, or how much they binged on Netflix, right? Those are their personal data streams that you're not, eventually you might have access to some summary statistics by them, to the extent that the individuals themselves begin to get access to that data. And we start to build smart analytics of about how to pull out relevant measures from those very personal, disparate, noisy, and only partially relevant sources of data. And when we have that kind of N equals me data, the data about me over time from many disparate sources, they can start to far improve and close these feedback loops of healthcare. The ones that we think of primarily have to do with clinical care, and obviously very important. The selection of the treatment, the titration of the treatment, how is this patient going to respond, and how are they actually responding to the care plan how are they preparing for whatever treatment they're going to have, and how are they responding afterwards, whether it's treatment for cancer or hip surgery or arthritis or back pain. Do I put them on opioids or not? How much do I give them? How do I get them off of them, and so forth? And then, of course, there's the patient self-care loop. When you're talking about chronic disease, since so much of our preventable deaths actually have to do with chronic disease, and so much of that chronic disease has to do with behavior of the patient, then that patient taking care of themselves, and in the context of family or by themselves or in community, is a huge predictor. And how does the patient decide what to do, decide what to stick with, decide what actually works for them, both what to start with, what to continue with, and what to change to, whether it's something that they purchase at the local Whole Foods, or at the local CVS, or something that their neighbor recommended to them, or something that their doctor recommended to them. And when their doctor recommends it to them and gives them a prescription and tells them take as needed, how do they decide whether this is actually needed and how much to take? And so now that is done very informally, a lot of retrospective recall in both of those loops. There's lots of standard guidelines about what you ask patients for things that you can't actually measure in a blood test or in a scan. There are clinical guidelines about those things, but still today they are largely based on retrospective recall in terms of how they respond. If you have rheumatoid arthritis, or if you have Crohn's disease, your clinician will ask you, how long does it take you to get out of the house in the morning? Very relevant clinical measure that we don't necessarily need to ask in the future. It's always good to ask, but we don't need to be dependent on the recall, because our phones know, and with a recorded history, we know what time in general you left your house in the morning. And so therefore your recall won't be biased by that catastrophic event, that's what you remember from the last 2 weeks or 2 months, and nor will we be biased by the sense of really wanting to communicate to your doctor that they're doing a good job and you're doing fine. And finally, and probably at this stage most importantly, and I think I undervalued it for a long time, is we need this more detailed data to generate research evidence about what works best in different conditions now that we start to have all this data. Because by and large, if you will ask a clinician who's operating under guidelines and under evidence-based medicine about a whole bunch of things, if I do X, will that help my Y? They will appropriately say, there's no such evidence. But the fact there's no such evidence doesn't mean that there isn't a relationship between those things. There just really has not been the appetite or the resources to gather that kind of evidence. That kind of evidence now is so much less expensive to capture really qualitatively that we can begin to gather data about what works for whom, what matters, what is the variability of response, what is the variability in symptoms are in any case. And as we do that, I'll come back to that at the end. We're really at a time when we have are starting to have what I like to refer to as sort of evidence engines to start to create this kind of evidence. Just before I get there, the data that can drive these better models of the user, of the patient. How are they responding to a medication? What is their functional status? What might a care coordinator want to reach out and intervene with them? How might we better understand somebody coming in because we better understood people like them in the past? Is informed, yes, very much by mobile, but mobile isn't just data from the phone, it's all the digital interactions. We now have so many more hours of the day because we're on mobile. And so it's the language we use in our email at a semantic level, grammatical complexity and affect, in addition to all the way down to the keystroke dynamics of how we're typing that email. If you think about impulsivity, for example, that it reflects both in the language you might use, the pattern and frequency you might respond to emails, as well as even your keystroke patterns. But is that something we're going to diagnose across an individual? No. We're going to see that for an individual, relative to their baseline, how do those small data streams about them, how do they vary from their baseline as we treat them and as their condition goes through its natural course of variation. So ultimately, we'll have huge amounts of this data, and we'll have a big data approach to being able to do things around diagnostics. But to begin with, there's a tremendous amount of improved care that can be given, and if I can't even use that term, precision, personalized medicine that can be given, not because we'll be diagnostic, but because we'll have a much better personalized view on how an individual is responding to care and what is their natural variability and their natural baseline. And that goes from location, as I mentioned before, to language, to maybe finally getting a handle on the dietary component of so many conditions, which is very, very difficult to measure in any passive way. But if from, for example, the money we spend on food, we can back from that to the items we purchase, and from that to at least our exposure to our food environments, even if we're not detecting everything actually digested, we have an opportunity to get at some of the most pervasive drivers of health, the food that we eat, that we choose, that we have available to us, in a way that we've just never had before. And so the biggest problems have to do with not just getting data, because we now really have availability to it. There will be many more great devices and wearables and sensors and Internet of Things that come about that contribute more data, but there's a tremendous amount we can do with what we already have. We can add to all of this the place devices, from echoes from which we can capture voice samples over time, to all the cameras that are being deployed for people's home security systems, et cetera. But it's from taking those raw measurements, since many of the available data points are secondary use. Amazon wasn't deployed to be able to tell you something about the nutritional components of what you eat. They were deployed to sell you things. So it's secondary use. The echo wasn't there to capture a voice sample several times a day. It was voiced to, sell you things. But that secondary use means that the data are particularly noisy, and we need the appropriate algorithms to combine these multiple data sources in a way that can actually tell us something. So that the data are there does not mean it's trivial to turn them into anything that's actually actionable. And of all these contexts, we heard about many in the space of this institute's convening. These are complicated problems. Health is very complicated. There's no one data stream that tells the story, and no one data stream that's going to fix the story. And so appropriate and smart ways of interpreting the data continue to be the holy grail here, really coming up with digital biomarkers that work. And in order to do that, and my final slide, we really need these evidence engines to help us do that. No one group or entity or one startup is going to do that, solve this problem in an affordable way that captures data about individuals and determines, well, yes, location is relevant both for Crohn's and for rheumatoid arthritis and for depression as one of those indicators. But how do you actually turn that into a measure that you could use in drug titration or a clinical trial on therapeutics? So ResearchKit that Sage BioNetworks and Apple brought to us a year and a half ago, lost track of time, is a tremendous push in that direction of establishing a common framework and including in that a very benevolent Trojan horse that encourages that data to go in a de-identified as possible way to be shared with researchers. And so they didn't just launch ResearchKit, they also just a year after launching, literally to the day, they published the data that had been gathered through one of the most interesting of those initial studies, the Empower study on Parkinson's. They published that data for the research community to begin to look at. And so there's really everything right, almost everything was absolutely right about that initial launch. A small thing that was missing was that, of course, we're not going to do medical research only on people who can afford iPhones. And so Robert Wood Johnson fortunately stood up, and we have an initial version of Research Stack, which is meant to be right side by side with Research Kit, so that when you launch a study, you can capture a broader demographics. These are both young initiatives in the scheme of things. It could fall apart through decay. It could fall apart by people going off and fragmenting more. And so I think my one call here is for all the people interested in this space and pursuing this space of increasingly leveraging data to better understand and treat patients, that we really try to do it together, because there's tremendous economy of scale that we need in this space.